Yeah, good afternoon again. I'm going to speak about aortic neck dilatations after EVAR, risk factor prognosis, and management. So what caused neck dilatation after EVAR? It happened really in both, even after open and EVAR. And the reason why, because continuance of aneurysm degeneration of the aorta. But in the EVAR, we have an extra forces can increase the risk of neck dilatation, like the self-expanding devices and oversizing, which may exert a continuous outward forces on the aortic wall. So what are the risk factors? We have anatomical risk factor, including the neck morphology, like conical angulation, thrombus, or size of the baseline aorta. We have a device factor like suprarenal versus infrarenal fixation, and self-expanding versus balloon expandable stent, and the sizing if you size over more than 20%. This is a very nice systemic review of the proximal neck dilatation after endovascular repair. They review about 26 articles from 1998 to 2015, and they review about 9,700 patients, and they found that neck dilatation occurred in about 24.6% of patients over a period of 15 months. So what they conclude that neck dilatation affect considerable portion of the EVAR patient and was related to the worst clinical outcome as indicated by increased type 1 endoleak migration and reintervention. But really the best paper came from Dr. Carlos Bishara, where he looked at the effect of stent graft active fixation oversizing on aortic neck dilatation after EVAR. It's a single center study. He looked at about 432 patients, and he did a yearly CAT scan for 4 years. And he measures the largest aortic diameter 1 centimeter above the renal and 1 centimeter below the renals. And he used different kind of the system. He used a Gore, Cook, Medtronic, Endo, Logic, and different kinds of fixation and different graft oversizing. And he followed up this patient on yearly CAT scan for 4 years. When he looked at the suprarenal aorta, comparing with the oversizing, he found that the suprarenal aorta dilate the most if you oversize more than 15%. For the infrarenal aorta, the same. The majority of dilatation happen when you oversize more than 10 to 15%. What about the fixation type? He found that suprarenal aorta will dilate the most if you use devices with suprarenal active fixation, comparing with the other kind of the fixations. And the same for infrarenal, again, the majority of the dilatation happen if you use a device with the suprarenal fixation. What about the graft size? He found that the majority of the neck dilatation happen if you use a device graft size more than 28. So what he concludes that after years that the group with the suprarenal active fixation showed the largest change in the aortic diameter over time comparison to the other two groups, and this was statistically significant. Also, he found that if you oversize less than 10%, then the incidence of neck dilatation will be the minimum, and again, comparing with the other group, and this was statistically significant. Another paper looked at the long-term evaluation of proximal neck dilatation after endovascular aortic aneurysm. It's a prospective cohort study. Look at 157 patients using EVAR or self-expandable stent, follow up the patient for 5 years with a yearly CAT scan, and they came to a very similar conclusion that the suprarenal aortic dilate about 1.8 millimeter at 2 years and 3.9 millimeter at 5 years. And they found a similar risk factor. Dr. Bashara found that oversizing more than 20%, neck diameter more than 28, and sac size at the index of operation are risk factor for neck dilatation after EVAR. Another new data came, again, with a new study, and again, this came up retrospective study for 150 patients, and again, they came with the same conclusion that the large neck diameter, suprarenal fixation, and oversize are the main risk factor for neck dilatation after EVAR. So what's the deal? How we can fix it? What's the ideal stent? Unfortunately, we don't have it. But one of the options is to use the Ovation Prime device, because the first FDA device which they don't use the self-expandable stent for fixation, but they use a ring for fixation, which is filled up with a polymer. And this ring will not put a continuous pressure on the wall, and this can prevent the neck dilatations. The other one to use a balloon expandable technology or conformable technology, but is not available until now. The other option is to use endo anchors, because if you look here, when the neck dilated, the EVAR will separate it from the aorta. But if you have an endo anchor, this can fix the graft to the aorta and prevent migration and type 1 endoleak. So how we manage neck dilatation, you can have different options. You can just, if the device moves down because dilatation, you can put just a cuff with endo anchors. You can do a chimney, EVAR, FEVAR. You can put some coil or onyx. You can do debranching, or at the end, you can convert it to the open repair. How we decide which technique we use, we look at the distance between the EVAR and the renal. If patient has a good neck, like more than 4 millimeter, with a good sealing zone, then this is a good case to go and put just put a piece there and just put an endo anchors. But of course, if you use endo anchors, the distance between the aorta and the graft should be less than 2 millimeter. This is one of our patient who was a follow-up after a couple of years. He came up with type 1 endo leak because the neck dilatation and device moved down. So we have to go there and put a cuff with endo anchor, and we get a good result. But if the distance between the renal and the graft is very short, then you have no space for endo anchors or cuff. Then you have to go suprarenal, and then you have this choice between CVAR and BVAR. How we decide, of course, BVAR is the best. It's our first options. It's a solid technology. We have a very good result with FEVAR. But of course, sometimes it's more expensive and need more technical skills, where CVAR is good for, emergency cases, quicker. But the problem with the CVAR, you have to deal with the gutter leaks. Onyx, sometimes we use onyx like these cases. Patient, you can see the graft is a good position, but the neck get dilated and he get type 1 endo leak. So when there we put some onyx, he will fill it up, and they put some endo anchors, and we get good seal. And this is follow-up CAT scan after 2 years. Debranching, we used to do it before we have an access to the BVAR and FEVAR. It's less invasive than open repair, but really now we use it these days. Like this patient, he came with the dilatation of the suprarenal aorta after open repair. So when there, we branch his renal, SMA, and celiac, and they put TVAR. So in conclusion, EVAR with the self-expandable stent and endograft oversizing create a radial force that lead to the neck dilatation, but this force decelerated after 1 year. The baseline aortic neck diameter and suprarenal stent grafting are associated with the increased risk of neck dilatations. And neck dilatation after EVAR lead to the worst clinical outcome because it increased the type 1 endo leak, migration, and reintervention. And proper placement of the graft just below the renal artery and using the balloon expandable stent could reduce the risk of neck dilatation, but the data are still not out or concluding. And finally, using polymer ring instead of self-expandable stent for proximal fixation, like in Ovation Prime device, may decrease the incidence of aortic neck dilatation. Thank you very much.